Okay, well, just as people are joining the meeting, I just wanted to give a few updates. So upcoming conferences today, we're going to hear about pharmacogenetic testing and a potential use in our patients, and establishing potentially a clinical workflow for our use in the Bartlett Clinic. And then we'll have some Bartlett Clinic updates with Sheila at the end of the session. And then the next week is the CFAR annual meeting with the Polk lecture by Rafi Landowitz. And I'll give you a little more information about that in the next slide. And then following that, we'll have a case probably, and then some EPIC smart phrase updates with Joyce and Julie. And I did want to mention, I booked a talk for actually early 2023 that I'm super excited about with an infectious disease dermatologist who I've worked with in the past, who does both domestic and global dermatology and specializes in infectious disease dermatology, and just a really dynamic speaker also. So he'll be here in January to virtually, at least, to go over some skin rashes. So for those of you who did not see the email, the next week is the annual CFAR meeting. Richard, I don't know if you have any comments about this, but I put at the bottom the link here to the Survey Monkey. I can put this in the chat as well to register for the CFAR conference, and then the Polk lecture, which will be next Friday during this exact time frame, from Rafi Landowitz on biomedical HIV prevention, both looking backwards and looking forwards. Anything else that we should know about that, Richard?
No, the only additional comment I'll make is it's not going to be, as far as I know, it's not going to be Zoom casted. So if you can, ideally, please attend in person the Frank Polk lecture, and any of the CFAR scientific presentations or poster sessions, you're absolutely welcome to attend.
Okay, great. Thank you so much. So I will stop sharing and introduce our speaker for today. So we have Dr. Jim Stevenson, who comes to us from the Department of Medicine and Clinical Pharmacology, did his training at University of Michigan, if I'm correct, and is going to talk to us about the potential role of pharmacogenetic testing in caring for our patients.
All right, thanks. So let me make sure the slides are showing correctly here.
Looks perfect.
Looks good. Not
Yeah.
presenter view.
No.
All that stuff.
Yep.
Okay, great. And I was going to mention a couple of resources in my presentation. So before I started, I wanted to put something in the Zoom chat, which looks like I might have to stop sharing real quick just to do that. Sorry, it's a little clunky.
No problem.
Okay. Hopefully those links are separate and not all mucked together, but okay. So back to the slides. Thanks for the opportunity to present today. I'm going to be talking about clinical pharmacogenetics, provide some general background information, and then talk about how actual workflows of using this might look if we were to do this on occasion with patients in the Bartlett Clinic. So a couple of disclaimers or context setting type comments I have before we start with this is that I'm not proposing that we use pharmacogenetics on every patient in the Bartlett Clinic or incorporate it into any of the standard workflows. It's just sort of a tool that I want to make available to multiple services throughout the healthcare system, including the Bartlett Clinic. And as you recognize me as sort of an outsider to this meeting, I only have my best guess as to how the workflows work in the clinic, so I have sort of a proposed process here, but I'm very open to discussing ways that can be improved. And I think really the ask at the end of this presentation is to identify one brave clinician soul who can think of a good patient where we can test this out, sort of a first single test case, make sure everything goes smoothly, figure out how we can improve this and make this a more readily available tool to be used on occasion by Bartlett providers going forward. Okay, so that's the end of my disclaimers. So we'll begin with a brief discussion about clinical pharmacogenetics, what that is, what I'm talking about, its place in therapy, things of that nature. So when I say pharmacogenetics here, I'm referring to the influence of genetics, differences in genetics between individuals on medication outcomes. So those medication outcomes can be efficacy related, toxicity related, or related to dose requirements. But I am talking about human genetics. I'm not talking about pathogen type genetics. And I'm also talking about germline genetics. So nothing to do with cancer, somatic mutations, tumors, things of that nature. So in terms of pharmacogenetics in the germline, a lot of it has to do with drug metabolizing enzymes, which are predominantly found in the liver. However, pharmacogenetics is not limited to drug metabolizing enzymes, but that does make up a large deal of the genes that we've studied and that we understand influence treatment response. So just an example here to go from the abstract to the more specific. On the left, we have the SSRI antidepressant escitalopram, which is predominantly metabolized by the liver to an inactive metabolite shown on the right. And the enzyme that is responsible for the majority of escitalopram's metabolism is called CYP2C19. It's part of the cytochrome P450 enzyme system that you probably learned about in med school and you think about for drug-drug interactions. And just like every other enzyme in the body, it's encoded by a gene also called CYP2C19. And most patients have a version of that gene that encodes functional enzyme. They have two copies of that gene that encode functional enzyme. However, some patients inherit a copy from their mother or their father of this gene that has a genetic variant that leads to a non-functional enzyme. And for those types of patients, they have drastically reduced metabolism of escitalopram to its inactive metabolite. So they have much larger concentrations of the parent compound escitalopram. And then they're at risk for dose or concentration dependent toxicities of that drug. And so if we knew this information beforehand, we could steer this patient to an alternative drug, or we could greatly reduce the dose of escitalopram instead of giving them a standard dose, seeing that they have toxicities, and then starting over again. So that's sort of the general principle of pharmacogenetics as it relates to drug metabolizing enzymes in the liver. A couple of big picture points about pharmacogenetics and our understanding of where it fits into clinical care now is that there's a bit of a fallacy that pharmacogenetics only benefits the 1 in a million outlier type patient. And while there is some truth in that, patients that are sort of on the extremes do end up getting the majority of benefit from pharmacogenetics, it's really not just for outliers, in that the drugs that are affected by pharmacogenetics are among the most commonly prescribed in the United States. So 1/4 of the top 100 drugs prescribed in the United States have pharmacogenetic associations that are known to impact outcomes and can be used clinically. So some examples there are in the sub-bullet. So it includes drugs that are used in cardiology, psychiatry, pain, others. And they're oftentimes slightly older generic medications that we tend to lean on a lot. So the drugs that are affected by PGX are common, but also the variants that are known to affect drug outcomes are also often quite common. So looking at that drug metabolizing enzyme in the escitalopram example previously, that enzyme was CYP2C19. So like I said, most people inherit two functional copies of that gene, one from their mother and one from their father. Most do, yeah, the majority do, but really about a third of patients have either one or two non-functional copies of that enzyme. So those people that inherit one non-functional copy of that enzyme, this is a simplification, but they have about a 50% reduction from normal in terms of their ability to metabolize drugs through CYP2C19. And those that have two non-functional copies of that enzyme, which is not a trivial amount of patients. It's about 3% of patients, or in certain ethnic subgroups, it's larger than that. Those patients have no ability to metabolize drugs through that pathway. They have no functional enzyme. So if they're given something like escitalopram, their only way to eliminate that drug is through the secondary pathways that are typically not leaned on to eliminate that drug. So sticking with the escitalopram example here, and that's really for consistency and not in introducing confusion in this short and introductory talk, rather than, it's not like escitalopram is the lowest hanging fruit in all of pharmacogenetics or anything like that, but I'm just keeping the example consistent across these slides so I don't introduce too many things. But like how does genotype end up affecting our clinical outcomes? So this is a paper from I believe a Danish registry. They have a unified health system there. So they have great population level data. On the x-axis here, we have CYP2C19 activity as determined through genetics. And there's, on this line, there's actually, I think, 5 different groups. Those with 2 non-functional copies, one with non-functional copy, those with 2 functional copies. And then there's actually people that have increased expression of this gene and higher than average CYP2C19 activity as well. So we're going from low to high CYP2C19 activity on the x-axis, and then the y-axis here is escitalopram serum concentration, all dose normalized. So all these patients getting the same dose, what does their escitalopram serum concentration end up being? And you can see there's a clear association between that serum concentration and the CYP2C19 activity as determined by genetics. But the thing I want to point out is the magnitude here. The magnitude is quite large. So looking at normal escitalopram serum concentration, dose normalized in this study, versus those with 2 non-functional copies of this gene, they have more than double. It's like 2.5 times the serum concentration from the same, when they get the same dose as the normal metabolizers here. So it's a pretty large magnitude of effect, which I point out because it's not lost on me that SSRIs, for example, are drugs with a fairly wide therapeutic index, a large therapeutic window. But we are talking about variants that result in large effect size and huge differences in drug concentrations. And second, as I'll show in further slides, obtaining this information, this genotype is often not costly and a fairly simple assay. And so if you can get this information for low or no cost and identify which of these buckets your patient is in, you might as well use that information to improve prescribing. Like, it doesn't make sense to give normal doses to someone that's in this extreme bucket over here. But knowing I'm from clinical pharmacology, you probably thought there would be some sort of pharmacokinetics slide, or something with drug concentrations in here, which you've gotten in the blue here. But I also want to point out that this is not just about drug concentrations, that this also affects clinical outcomes. So this is from the same study here, where the x-axis is the same. It's different levels of CYP2C19 activity. But here, the y-axis is the fraction of patients that discontinued escitalopram or switched to a different medication during follow-up. And so that's a very clinical outcome. Oops. And you can see it's a almost picture perfect U-shaped curve, where patients that are close to the normal CYP2C19 activity discontinued the drug about 12% of the time, and then more than double that amount of switching or discontinuing the antidepressant happened on the extremes. Patients with low CYP2C19 activity, so those patients likely discontinued due to tolerability issues, and then those on the far extreme in terms of increased CYP2C19 activity, we would expect that those patients discontinued due to lack of effectiveness. So this isn't just about drug levels. Pharmacogenetics also correlates or is associated with more meaningful clinical outcomes. So why would we want to use pharmacogenetics in clinical practice? Well, number one with the bullet here is to improve clinical outcomes. And this is mostly seen in patients that end up being tested and find that they are in that poor metabolizer group, or those on the opposite extreme, the ultra rapid metabolizers, et cetera, where we see that they're more likely to discontinue due to tolerability or efficacy type issues. Another is patient satisfaction and patient trust in the medical decision-making process. Patients do like to hear that you're considering individual factors and not just treating them through a straight algorithm or standard process. And that can lead to increased adherence and trust in the medical system, as I said. And last, I hesitate to say this, and I want to make sure I'm very clear about this. Using pharmacogenetics in the clinic is primarily a clinical or improving patient outcomes type effort. But by doing this type of work, we can collect those patient outcomes and provide a research base back to the scientific community to improve the way that we use this. However, what I'm talking about today, there is no research protocol involved. I'm talking about using this in a strictly clinical sense here. So I don't want to be misunderstood on that part. I'm talking about using this in the clinic to improve clinical care and not on a research protocol. Okay, this is my only vanity slide in the slide deck here, but as I'm a relative outsider of this group, I thought it would be important to briefly cover. Again, my name's Jim Stevenson. I'm a clinician scientist in the School of Medicine. We have a small division here called clinical pharmacology, which has the primary faculty all have their own sort of primary specialty in terms of therapeutic area. Many of them happen to have interest in infectious disease. My expertise is more in pharmacogenetics and how that can be used clinically. A big part of my training and research has to do with psychiatric medications as well, but I do consider myself a pharmacogenetics generalist. I also want to point out that in some of the things I describe here in terms of workflow involves me making treatment type decisions, or not decisions, treatment recommendations, I should say, to providers. And I want to point out that I try and keep my clinical decision-making muscles strong. I'm a residency trained pharmacist, and my fellowship was in psychiatric pharmacogenetics and implementation of pharmacogenetics. The other important bullet points here are that I'm upstairs here in Osler. I'm not far away. I'm not at Bayview, et cetera. So I think for trying to pilot and hone some clinical services that could be available to patients in the Bartlett Clinic, I think it's feasible, at least initially, to have it be sort of high touch. I can come down and help put out fires that I might have accidentally started, et cetera. I'm not far away. And then the last point is, although I'm a clinician scientist, my main goal here is not to get as many R01s as possible. It's in fact to improve the way that we use pharmacogenetics in clinical care throughout the healthcare system. And to be frank, I think there's a lot of opportunity for improvement there. I think that's the political way to say it. Johns Hopkins is kind of behind its peers in terms of top tier academic healthcare systems and using pharmacogenetics in clinical care. I'm trying to help us catch up. Okay, so why would we want to do this in the Bartlett Clinic? The main incentive for me is that trying to imagine places where we pilot pharmacogenetics and start to use it in clinical care at Hopkins. One of the low-hanging fruits is high-touch services with affluent patients that wouldn't mind paying cash for a consultation or a test that's not covered, et cetera. But I don't want that to be the only context in which patients can receive precision medicine at Hopkins. You know, I don't want to only be providing that type of service to affluent patients. So by piloting this workflow and this type of service in the Bartlett Clinic, it can be sort of a demonstration that we can provide this type of service to patients all across socioeconomic statuses and disease states. Second, of course, we want to improve the care that we provide to our patients by giving them medications at appropriate doses that'll improve adherence and satisfaction with the care that they receive. And then later on, I anticipate that testing in appropriate contexts will be reimbursable for Medicare and Medicaid patients. And then lastly, I want to pilot pharmacogenetic services in a more high-touch type environment before offering it to sort of every provider and every service throughout the healthcare system. Okay, so moving on to sort of from background and what is pharmacogenetics into what does PGX testing entail. I also forgot to say this at the beginning, but if anyone has any comments or questions, I'd be happy to turn this into a bit of a discussion rather than a lecture. So please go ahead and unmute yourself and ask any questions as they come up. I don't think with like the screen I'm seeing here that I would see questions in the chat. So if any of those have already come up or you have any questions, if someone can interrupt me, I would be more than happy to be interrupted. So what does pharmacogenetic testing entail? So I think it's important to know that pharmacogenetic testing is quite different than sequencing, whole genome sequencing, whole exome sequencing. We use highly targeted assays that are only looking at pharmacogenes. So that's good for a couple of reasons. One is cost, one is technical complexity, but I think a big reason that's a good thing here is that we don't end up with incidental or secondary findings or variants of unknown significance. So these types of services typically don't require the use of a genetic counselor or finding something that's that we weren't looking for, that we have to end up interrogating through bioinformatics, or something that we weren't expecting that we need to disclose to the patient and trigger cascade testing for their family, et cetera. We're only looking at pharmacogenes that have limited impact on disease risk, et cetera. Like I said, we are primarily assaying drug metabolizing enzymes, as well as a few drug transporters, a few drug targets, et cetera. And then finally, pharmacogenetics is really just a piece of the puzzle. So we use these test results in combination with non-genetic information to try to improve the drug prescribing here. So how is the testing actually performed, or who does it? As of now, there's dozens of third-party reference laboratories that will run pharmacogenetic testing in a CAP and CLIA approved environment for use in clinical care. Our Department of Pathology is developing an in-house pharmacogenetic assay that it seems close to ready for prime time. The technical validity is there. We have a bit of a sticking point with actually the informatics piece, literally getting the results off of the instrument and into Epic, which seems so silly to have that be the rate limiting step, but that's where we're at. They're trying to build it to scale and not to have manual entry of the results, et cetera. And so our in-house test is not orderable in Epic right now because of that bioinformatics piece is still being worked out. But hopefully that'll be available in the next calendar year once we get that straightened out. But for now, we're limited to third-party reference laboratory sendouts, which to be quite clear is the way that most academic health systems are performing their pharmacogenetic testing. There's trusted companies with valid assays and good business practices, et cetera. What I'm going to recommend to use in the services that we're piloting right now is a company called Invitae, which is used quite frequently for medical genetics, disease risk genetics, by our Department of Medical Genetics here, and has a long track record of genetic tests appropriate for clinical use. They have more recently dipped their toes into pharmacogenetics, versus a lot of the other testing companies are the other way around, where they their pharmacogenetics test is their flagship or only offering, et cetera. But I want to be clear that I have no connection or conflict of interest as it relates to Invitae. But there's a couple of reasons that I thought that would be the most appropriate for these things that we want to pilot. One is that it's a buccal sample. So if we're seeing outpatients, we don't need to subject them to a blood draw that they would otherwise not need. Invitae has very strong and transparent billing and reimbursement processes that I think are going to be important for seeing if this is going to work out as something that we can offer more routinely for patients in the Bartlett Clinic. And then they also do have an automated process to get discrete results into the EHR, which we don't currently have activated right now because our testing volume through pharmacogenetics through that company is zero right now. But if this is something that we're doing more routinely, we could get that informatics pipeline opened up. I'll also say on the topic of testing companies, if by chance in the context of the Bartlett Clinic or any of the other services that you work on, if you have pharmacogenetic results from any testing company and want to talk to someone about them, I am happy to weigh in. Like I said, I have no connection to Invitae. They're not the only option. Other academic health systems use other testing companies, et cetera. So they're not the only good or valid company out there, but I think for our purposes, they make the most sense. So I also want to talk about paying for testing. The slide layout's a little bit weird, but bear with me here. So on the left here, Since a 2021 update to CMS policies in our region that I worked on in concert with other pharmacogenetic specialists in our region, we were able to get the CMS policy in our region revised and improved to cover pharmacogenetic testing, to reimburse pharmacogenetic testing as medically necessary for more than 100 different medications that are known to be affected by pharmacogenetics. So that's a big improvement from where we were in terms of reimbursement in 2020, and prior to that, they would cover pharmacogenetic testing for only about 5 different medications. So now almost all the indications in which I would want pharmacogenetic information, or I think it would be appropriate to use in clinical care, are now reimbursable by CMS. Private payers, I'm not an expert in the financial space. My understanding is that private payers tend to lag behind CMS policies in terms of what they reimburse. So it's kind of a mixed bag right now, but for Medicaid and Medicare patients, this should be reimbursable. So the language on the right column here is directly quoted from Invitae, the testing company. So basically they say in bold there, most patients who have Medicare or Medicaid will not receive a bill that will be fully covered by their insurance. And then the second bolded part in the bullet point there is that before they run anything, they will check the insurance documentation, sort of do a prior auth on their side, and they'll notify patients if there's any expected out-of-pocket costs. At which point we can just say, no thanks, that wasn't our intention, so don't run the test. And then the bottom left bullet there, that's why I said this slide format's a little strange. There are other options on how this test can be paid for. Patient self-pay is an option, probably not a good option for many of the patients in the Bartlett Clinic, but I'm just being transparent about how this works. You can also set up an institutional billing fund if we wanted to do something that was grant supported, or if Hopkins leadership wanted to create a bit of a fund for patients with all sorts of different payers to make sure that they never got a bill. I personally think it would be interesting to try out and see if the Medicaid and Medicare patients, if the no out-of-pocket expense works as flawlessly as advertised in practice here. So I would kind of suggest as sort of our first test case to maybe identify a Medicaid or Medicare patient to try this on. So in terms of actually outside of the testing, how would the clinic visit or the consult note type work? I think there's 2 different options that we could explore and have them both available. One would be an in-person visit with me. That would be sort of in the format of a clinic visit, an outpatient clinic visit with a PharmD, in which case I would discuss the results with the patient. Of course, the patient would be told not to change any medications or doses without consulting their prescriber, but there would be patient education during this in-person visit. And then there would be a clinic note that would provide recommendations to the prescriber about how I would recommend that the test results be applied to the patient's current medications and any medications that are being considered. In terms of this clinic visit, I would recommend that we do this physically in the Bartlett Clinic. Like I said, I'm not far away, so that would make sense to me. Clinical pharmacology doesn't have any clinical space of its own right now as well, so that's another good reason that this would probably be done in the Bartlett Clinic. And that would be documented and reimbursed as a sort of PharmD outpatient clinic visit, which you may or may not have that sort of visit context already set up. The other option, and I'm not sure if this is used in other contexts by the providers on the call today, would be an e-consult. So an e-consult is an asynchronous provider-to-provider communication, in which case provider A asks for, it's sort of like a formalized process for getting curbside recommendations. So provider A asks a clinical question to the specialist. The specialist answers that question in the form of a e-consult note that goes into my chart. And so that's the other way to do this, especially if the patient is not particularly interested in coming in for a clinic visit or doesn't want patient, it's not important for them to get a patient education session about the pharmacogenetic results, et cetera. We could just do an e-consult with no in-person visit. And pharmacists can't bill for these, as far as I've been told, which is fine because generating revenue is not something that's not one of the goals of introducing this to the Bartlett Clinic or really anywhere right now. And we are building a pharmacogenetics e-consult that is likely to go live very soon, not just for the Bartlett Clinic, but for providers across the hospital to have access to. Okay, so getting down to workflows, and I think I told Eileen I'd be careful and make sure we don't go over times for other announcements at the last 15 minutes here. I think I'm close on time here. So how would this look? I think the workflow that would work is if the Bartlett clinician sees a patient face-to-face during a routine visit for other purposes, identifies them as a good candidate, and obtains the buccal cheek swab right there while they have the patient there in the clinic. And then I have a small stack of testing kits that come with pre-addressed, prepaid envelopes that can be dropped into the mail via FedEx and I think USPS are the two options. It's also important for me to say that the kits are shelf stable before and after the sample is collected. They don't take up a lot of physical space. They come in a flat FedEx envelope, et cetera. And then the test turnaround time is 7 to 14 days. So perhaps the next time the patient is coming in for an in-person clinic visit, we can tack on a 30-minute clinic visit with me. Or if we're doing an e-consult, that can be done as soon as the test results are available. It doesn't really have anything to do with the next time the patient's coming in. Okay, so a big question we should discuss here is who's a good candidate for PGX testing. There's no extremely clear answer to that, unfortunately, and I think it's one of the big unanswered questions in the field of clinical pharmacogenetics right now, and in terms of making this cost effective, and should we do this as standard of care? Does this show benefit in an RCT, et cetera? So who's a good candidate for PGX testing? Well, if the patient is interested, that's one criteria, especially if we're talking about doing the in-person clinic visit model. Patients with a history of medication intolerance, especially for drugs that are known to be affected by PGX, especially if they have a history of dose or concentration dependent toxicities. Patients with idiosyncratic type drug reactions, pharmacogenetics is a little bit less developed in predicting those. On the opposite end of the spectrum, patients that have had ineffective treatments despite adequate doses and adherence, that could be due to pharmacogenetics. And then if you're considering initiating treatments that are known to be affected by PGX or pharmacogenetics, that would be another criteria. And then I think in terms of the very first patient pilot here, Medicaid or Medicare coverage, I think makes a lot of sense. We can see if that works out in terms of ensuring no patient out-of-pocket expenses with the Invitae test. So I referred to drugs affected by pharmacogenetics in that last slide. That probably doesn't mean a lot to most of the people on this call. I define that using gold standard resources. One is CPIC, or the Clinical Pharmacogenetics Implementation Consortium, of which I'm a member. That's a academic consortium, international, that provides guidelines about how to use pharmacogenetic information in clinical care. The other is the FDA has sort of a list or table of medications where they also recognize the influence of pharmacogenetics on dose, toxicity, or efficacy. Some of the examples are listed on the right. A lot of them are in the neuropsychiatric space. There's a few good examples from infectious disease, and then I put internal medicine, but it really means other there. Other commonly used medications like PPIs, NSAIDs, statins, and clopidogrel are also known to be affected by germline pharmacogenetics. Okay, so a couple of examples about what would maybe be a good patient in terms of their clinical situation. Like I said in the previous slide, a patient with a history of treatment limiting ADRs at a relatively low dose of a PGX drug like escitalopram. Now you want to start a new antidepressant and want to figure out if their previous ADRs were maybe influenced by pharmacogenetics. And we could maybe use that information in determining an appropriate new drug for them. So that would be an example. Maybe you're just starting an antidepressant new, but the patient says like, yeah, that sounds neat. I would like you to use that type of information in the clinical decision-making. Like past intolerance is not part of the reimbursement scheme or criteria. So if you're considering drugs affected by PGX, even if there's no history of intolerance, that would be appropriate and likely reimbursable. Or if there's a situation where you definitely need some piece of pharmacogenetic information, but wouldn't mind getting additional pharmacogenetic information on other drug metabolizing enzymes or drug metabolizing enzymes going forward for management of other disease states. That's what's trying to be conveyed in that third bullet point. Okay, so here's the process overview for an in-person clinic visit. I see we're getting close on time, so I'm not going to read this slide out loud to you. My intention with this workflow is to try and minimize the pain points for the Bartlett providers here. I do think that collecting the buccal sample while the patient is already in the clinic with the provider makes a lot of sense, and that's why I'm proposing to do it that way. I'm proposing that I place the order on the Invitae website to try and offload that task and the need to register, et cetera, to the Bartlett providers. Eileen, I see your cameras come on. You're probably going to give me a time warning here.
You're fine. You're fine. No.
Okay. I'm happy to distribute these slides as well here so people can take a better look at this. But the e-consult process is similar, although there's no scheduling of the follow-up visit because there is no follow-up in-person visit. I did want to talk about this briefly in a group setting here as to whether or not this is going to be feasible. These are things I would need in terms of placing the order on the Invitae website. One is, specifics about insurance, what their insurance coverage is and their member ID number. Phone and address is also required. I imagine that some of these patients don't have a stable mailing address. So I don't know if that's going to be a common barrier or if that is maybe a non-issue. But then medications being considered, I think I can get that information from communicating with the Bartlett provider. And that's important for the reimbursability of the test. My last couple of slides, I think I'll go through quickly because they're not all that important and I want to save a couple of minutes for discussion. But the results will come back with these diplotypes and sort of an interpretation. And the Bartlett provider will not be on their own. I'll be providing treatment recommendations based on these reports. So you'll get that information, but you'll also get it applied to the patient case from me as well. So, all right, last slide. So there will be a couple of minutes for discussion. The takeaways are that PGX, everything I've talked about today is not for research purposes. This is all in a clinical context. PGX can be used in clinical context, and I want to improve how we do that throughout the healthcare system, including the Bartlett Clinic. Takeaway 2 is I'm doing my best guess as to how these workflows would work. I probably got a couple things wrong, but I'm asking for someone on the call to be the first brave clinician to identify a good patient and work through this with me. And so we can iron out this process a little bit better. And then third is don't be a stranger. I'm just upstairs. My email address is my last name. And I'm happy to talk about this process, happy to make this high touch as we figure things out. And I'm not asking for this to be done in every single patient or as part of your order sets or anything like that. But let's start with one. Let's iron out the process and then have this be something that is, just a tool in the tool belt of the greater Bartlett provider population. All right, so I think that's the end of my slide deck. I see there's something in the chat, but I haven't looked at it yet, so I'll stop sharing and maybe we can talk for just a minute or two.
Well, thank
I
you
see there's
so
a
much.
request to distribute the slides. I'd be happy to do so, and I think that would be helpful for everyone.
So Jim, if you send them to me, we'll put them up on the Teams channel for the CFAR conference. So, and it's also ID week, so we don't have as many of the providers as we would sometimes have. So we'll make sure to re-announce that. But this is really, really helpful. Just one quick question in terms of you mentioned that we're unlikely to trigger a lot of cascade testing with this type of focused screening. Do you routinely counsel someone if you identify that they have a variant that do you tell them to tell anyone in their family, or do you just say, this is a variant that you have, like, for example, for an antidepressant?
Yeah. So there's no objective ethical or legal responsibility to report findings or trigger cascade testing in the context of PGX. Depending on patients' understanding and interest in receiving that type of information. If the patient said, I have this, my dad is on Plavix, does that matter? If the patient had adequate level of understanding, I would share that information, but it's not a standard or it's not a process that is routinely triggered. Like, for example, if you have 2 non-functional copies of that enzyme CYP2C19, you know that your dad and your mom both have at least 1 non-functional copy too, which has treatment implications, but they're not part of the genes that the American College of Medical Genetics requires that you disclose that and identify family members, et cetera.
Well, thank you. I'm sure there are more questions. I would just encourage people. So the link that Jim posted at the beginning does take you to that FDA website that gives a description of lots of medications that have pharmacogenetic. So if you're like, how and who would I apply this to? That's a good place to just browse through. And then, and there's another question in the chat. What is the cost as compared of target test sequencing compared to full sequencing? Yeah,
so if someone were to pay for this test out of pocket, it's $250 for this targeted assay. If you were to pay out of pocket for clinical whole genome sequencing, don't quote me on this, but I would expect that to be in excess of $2,000. And there's a lot more information that you get from that, which can be good and bad. It can be a double-edged sword because you find variants of unknown significance, which means you're not sure if it's pathogenic. You get information on genes that affect disease risk that then you are obligated to communicate to the patient. They need to talk to a genetic counselor, et cetera. So there is some benefit of having these more targeted assays.
And Akima, did you want to ask your question? You were wondering about that. Did that answer? If you want to unmute, go ahead. Okay, so I guess that.
Yeah, I think it's okay. That's what I wanted to know, because I was just thinking of the incidental findings, how useful it might be if we eliminate them. We might be losing something, and we might not be treating the patient holistically.
Yeah. Yeah, there's pros and cons to both approaches, certainly.
And so I guess that all, so Sheila is going to do our clinic update when we do epic phrases in a couple of weeks, so we can relax. So I'll just ask another question, which was, I think as we talked about in our, before you and I, we do pharmacogenetic testing, like with the abacavir hypersensitivity HLA typing, which all of us would routinely order before administering that medication. I was wondering about that one point where you're like, if you're going to do that testing and you would want more information. So would that be where you specifically request from Invitae, like the HLA 4-digit testing and also something relevant to an antidepressant or to Plavix, or how would you envision that working? Because we do send that in people, though abacavir is less and less used.
Right, yeah, so what the Invitae test is a panel that has is looking for significant markers or clinically actionable markers in a couple dozen genes, including HLA-B. So if you did have a patient that was starting abacavir and you knew that they were going to need that HLA-B screening for abacavir, you could ask for the Invitae test and get that information in addition to all this other information. And, if it was a Medicaid or Medicare patient, that would likely be $0 out of pocket for that patient. You would get what you need for abacavir, and then you would have other information that could help improve prescribing for their comorbidities. I'm not trying to make everyone order, use Invitae for HLA-B screening necessarily. Like I said, I have no connection to the company, but for patients that are likely to get drugs for other purposes, if we can get that type of information for $0 out of pocket for the patient, that sounds like a good thing.
And anyone else has any questions, please feel free to either put it in the chat or unmute, but I'll just ask one more, which is, do you think it's most useful in people who've experienced adverse effects from drugs? Like in your experience, like who is most, there's also always the very curious people who also want full body CT scans, but in terms of like a patient who has drug hesitancy, like who is that patient?
Yeah, so I've found in other contexts, like patients, like affluent patients that want to pay will pay whatever to get pharmacogenetic testing and talk to someone in the clinic. They're often patients that have had a lot of drug intolerances. And sometimes the PGX results help to explain that. And sometimes it doesn't. So, there's other reasons people get drug toxicities. There's probably some degree of subjective sensitivity to the effects of drugs as well, and the detection of ADRs, et cetera. But like in terms of cost effectiveness, or if I was, if you were making me design a clinical trial where you were going to say, like, I need you to show that PGX testing is cost effective in this patient population, I would try to enrich it with patients with past toxicities, especially past toxicities to drugs that go through these pathways. But in terms of clinical use and thinking about this in just a clinical context, especially where there's going to be coverage from the payer, past intolerance is not a requirement, et cetera. So that doesn't necessarily have to be a checkbox that you have to check off there in identifying a good candidate. I don't know if that was a great answer, but it was a little bit of a rant.
No, I think that makes sense. And
because if you're looking at a single gene, like 70% of people for that one gene that I use as an example are going to be normal metabolizers, and the test for that gene is going to be like, you're going to treat them as usual. But we're going to look at several dozen genes if you run this panel on them, and they are going to be at one of the extremes somewhere. So people, you'll find sentences and papers that say like 99% of people carry an actionable pharmacogenetic variant. So everyone's like an outlier through some pathway.
And I guess just one other question in terms of like thinking about this type of testing as opposed to looking at drug levels, and which would sort of be a back end approach. And I think we do for some of the like, and azole antifungals and things like that, where it seems like for, I saw you mentioned voriconazole, maybe
Yeah.
you could predict before you do the levels, but just wondering your thoughts on that.
Yeah, so I think they're complementary. I don't think there's a future in which pharmacogenetics makes therapeutic drug monitoring obsolete by any means. However, this is a bit more preemptive in which you can, you don't have to expose the patient to a drug that might cause toxicity and get them super therapeutic, et cetera, beforehand, or the opposite, drugs that they're going to chew up way too fast, voriconazole included, and then later on you find out that they weren't covered as you waited for that TDM result. So they're complementary, and some of the drugs that are affected by PGX don't have readily available TDM, like things like statins, SSRIs. You might be able to find an assay somewhere, but they're not commonly available or orderable. So I think they're complementary tools.
Okay, great. Well, I don't see any other questions in the chat, but if you share those slides to me, I will put these up in the Teams channel, and hopefully there's someone among us who's ready to take the first step and try to figure out how these services could benefit patients in Bartlett.
Yeah, I really hope so. And like I said, we are just like sort of searching for maybe a N of 1 pilot here to work things out. Hopefully the wheels start turning with some of the people on the call and they can think of a patient maybe that sounds like this. And my last sentence here is, like I said, don't be a stranger. Stevenson at jhmi.edu if you want to talk about this. Doesn't have to be through formal consultations or anything like that. It can be high touch, and we can talk through it at the beginning.
Well, great. Well, thank you so much for taking the time to be here, and thanks everybody for joining, and we'll see you next week in person for the Polk lecture, and have a great weekend.
Thanks for the opportunity.
Thank you.